Here with Dr. Molly Martinez. Thanks so much for coming. Looking forward to chatting with you.
Yeah, thank you so much for having me. It's very, very flattering that you consider me a interviewee. So thank you.
Well, you do have your own practice, and so maybe you could give us a little bit of a background of your professional journey leading up to where you are now and what you are doing now.
Yes, sure. So I kind of took a circuitous route to being a psychologist. I took a lot of time off before I went back to grad school, and I actually initially went back to grad school to be an English professor. So I was in a
Cool.
doctoral program for English,
Wow.
um, and just realized that that wasn't a good fit for me. It was very much this too like kind of ivory tower and disconnected from really directly helping people. And I had kind of sat the fence between psychology and literature before I chose literature, because I did have an undergraduate minor in psychology. But I chose to switch paths. And that meant I had to kind of go backwards. And that's sort of a theme in my development as a professional, is that, you know, start in one direction. If it doesn't seem to fit, back up. Or if there's things that get in the way, sometimes you have to back up. So I actually ended up getting a second bachelor's in psychology because I knew I wanted to go to a doctoral program, and there were certain requirements that I had not met in order to get into graduate school, like research hours specifically. And so I went back, got research hours, and applied to graduate programs in psychology. I did not get in the first time I tried because primarily not enough research experience. So I worked as a study coordinator at a mood disorders lab, and then was accepted to the program the next year. I, went through the gauntlet of a doctoral program in psychology, and was late in life. So I ended up having getting pregnant with my first child in my internship year, which is a really intense year. I took some time off, got licensed, worked in a group practice, general group practice, where I actually was doing a lot of ADHD assessment, adult ADHD particularly, and realized it wasn't really my fit. I didn't, I'd had several patients with OCD in my training, and then there wasn't a lot of evidence-based treatment happening in the general practice for that I worked initially. And I ended up getting all the OCD patients because I was the one that would be willing to say, all right, you're having panic attacks when you drive. Let's go out and we're going to drive your car and we're going to get on the interstate. And everybody was like, what is she doing? Is that okay? But I was like, this is not only okay, it's what we have to do to treat these disorders and to treat anxiety best with exposure. In the OCD patients, I just kind of fell in love with them and how fun it was and creative. And so I started to specialize. Then we moved to Texas from Ohio, where I was initially licensed into by training. And because of the licensure difference, I had to actually go back and repeat a postdoc when I came to Texas. So I'd been licensed for 3 years, but because I hadn't done the postdoctoral requirements that Texas required, I had to go back and redo a postdoc. And I was in a second group practice, this time more specialized in anxiety and OCD. And then after about a year and a half and baby number 2, I launched my private practice.
Nice.
So that was in, that was 2018. And it's just kind of grown steadily from there to now I'm at a point of hiring, and I've got 2 undergraduate interns, 2 doctoral students, an administrative assistant, and a new hire coming on board that's a licensed clinician.
Nice. Congratulations.
Thank you.
Where'd you do the PhD?
I did it at Ohio State University.
Okay. Did you like it
Very
there?
research heavy, very research
Yeah,
heavy.
right. That's what I heard. Yeah.
It was. And so it was the main reason I went there was because my husband got a job as a professor there. He had a couple of different job offers, and part of our decision making around Ohio State was because of the doctoral program that was really kind of like I hadn't gotten into. the first time I applied, but I did get the research position, and luckily I got in the second year after taking that advice on what I needed to do to be a stronger applicant. But yeah, it was very research oriented. But I had the good fortune of being with a mentor that supported my goal to be more of a clinician. Yeah.
What was your research interest?
So I was in the child and adolescent clinical psychology program, and the lab that I was a part of was a childhood mood disorders lab. So one of the few research labs at that time studying primarily bipolar disorder in children.
Gotcha.
So I was with Mary Freistad, and she had been the chair or president, whatever you call it, of Division 53, which is a child and adolescent section of the American Psychological Association. So she was very prominent in that area, and it was research. It was pretty controversial at the time, and maybe still, but it didn't start at, with anxiety and OCD as a specialty. It's more about mood disorders. And so in different levels of my training, I looked at family history of bipolar disorder contributing to early signs of hypomania, mania in children, and then expressed emotion as a factor contributing to psychopathology and mood disorders in kids. And my dissertation was on suicide-related behaviors in children ages 8 to 12, and looked at some of the factors that were associated with kids that made gestures or attempts at hurting themselves, killing themselves.
Does DSM-5 have a diagnosis for child bipolar?
It doesn't have it's a good question, because I studied under DSM-4, and it doesn't have an age limit. So technically I think there are some more descriptors of what it might look like in children, but it's never had that, like personality disorders, you have to be 18 or older to have that diagnosis. It's just that it's generally assumed that we have this section where it's disorders that are common in children, and the idea that this is where you find diagnoses for kids versus in these other places, like the mood disorders. And I always kind of thought that didn't really make sense, because when you actually get a diagnosis in adulthood, most people report, oh, these symptoms have been there for as long as I can remember, or many of them anyway do. And it's not like we become a different species when we age. It's your brain is your brain, and those early signs, even if they don't meet full criteria, which they typically still don't meet full criteria for mania, doesn't mean there aren't these symptoms bubbling up at an early age when you can intervene more appropriately if you recognize them.
Exactly. So going into your current practice, can you tell us more of the mission of that practice currently, and where you hope to take it?
Yeah, so my practice is specialist in OCD and anxiety recovery. The acronym SOAR, as what a lot of people know my practice by, and we're in the Dallas, Texas area. And my mission is really to reach out to this underserved population of people with anxiety disorders, and particularly OCD, that aren't getting the evidence-based treatment, primarily exposure and response prevention, but also some of the kind of newer emerging evidence-based treatments like acceptance and commitment therapy. And I haven't really done inference-based cognitive behavioral therapy, but I'm really following and I kind of learning along informally to that kind of research development and newer intervention.
I'm not familiar with inference-based CBT. How would you describe that in a nutshell?
So it's Frederick Ardema, who's up in Canada, has done a lot of research about just sort of a different approach that doesn't really involve exposure, but is more metacognitive. So thinking about your thinking, which clearly we all already do with exposure and response prevention, as well as just general CBT. You're not just what are the thoughts and trying to change them, but how are these thoughts functioning and how, there's a metaphor that is used in ICBT. And I also want to just full disclosure, I am not an expert on it, so not going to be able to lay it out, step by step. But one of the metaphors that I feel represents well, at least a piece of what ICBT does, is the idea that we, when we're in a state of being very preoccupied by an obsession or an intrusive thought, we cross a bridge from reality into sort of a fantasy world. And ICBT focuses a lot about doubting. The place that we go into with doubting our senses and our reality, and trying to move away from, like, recognizing that this doubt is exists in a fantasy world and coming back into reality, and getting a perspective on that thought process. So people that practice ICBT are very insistent and clear that this is not the same as exposure and response prevention, or even exposure, so much as learning how to really let go of this doubt and this doubting process and come back to the present reality.
Mm-hmm. Interesting.
There's a lot about the feared self as well, in terms of you kind of getting wrapped up in this idea of who you're afraid you might be versus who you are and know yourself to be. So.
Mm-hmm. Okay. Oh yeah, always interested to hear about new developments in the field. Okay, so you're at an exciting time in your practice. You're growing it. You've been going for about 5 years. What's your dream with your practice? What would you like to accomplish?
I would really, so because I'm in the DFW area, and we've got a population of around 7 million people in the extended sort of Dallas Fort Worth area. And I've really worked hard to connect private practice clinicians in this area. I started up a collaboration and network group called Dallas OCD Treatment Specialists, or DOTS. And most of us, all of us initially were really in solo private practices, and are able to connect and support one another better. So Justin Hughes, Nathan Peterson, Reagan Possum, Jeremy Rudd, several of us. And when I started that group, I reached out to pretty much everybody I could find in the OCD or the IOCDF listserv, or in Google searches of professionals that treat or specialize in OCD in this area. And, 8 to 10 popped up. So you can imagine with our statistics, how many people need this evidence-based treatment and aren't getting it because there's just not enough practitioners out there. So with my practice, my passion is to train more people that know how to do this well, and duplicate myself. And so bringing aboard more clinicians. We don't have a group practice of private practice outpatient clinic specifically for OCD, and expanding the services that I offer, and by training more professionals, and beyond my practice, within my practice, once I do that, I feel like I will be able to offer more free services, be able to do more outreach, and groups and things like that are gonna, again, reach more people. And there are a few other things that aren't necessarily related to my private practice that I also would love to, do more of.
So what are the tangible benefits that you've experienced so far from starting DOTS?
Did you say tangible benefits?
Yeah.
Yeah. So, not feeling alone, I think, is a big one. Knowing that there are other people out there. I think we can get very lonely, especially in solo private practices. And I'm the kind of person, I don't want to, it's not just exclusively about training. It's also like, I want an environment, I want to create my dream job. I want an environment, having been in group practices, there are definitely some downsides. And I really hope to kind of offer that supportive environment that values the clinicians and we don't burn ourselves out. And so being able to make those connections outside of my individual practice was vital at DOTS, creating a professional social network as well of we do a lot of consultation, which I think is really integral to doing good clinical work, can refer to one another, can just, kind of process hard days or difficult cases, and benefit from the expertise of others. So we've got Blair Kinney's in the group, and she's trained a lot in DBT and radically open DBT. So she's always the one that we kind of go to for learning about that, or even referring if it feels like an appropriate referral. And Lisa Bazil has done EMDR training and is working with trauma and has seen does a lot of work and working with the fire department and the things that they see and go through and helping their emotional health. Justin Hughes and Renee Osborne both have a kind of niche in blending spirituality and Christianity in with treatment. So it's just learning and growing from one another and supporting one another has been really invaluable. COVID kind of messed up our plans for offering monthly support groups, but that's another thing that is sort of a vision that we would like to do together is, it's really difficult. One clinician in the area, she has not been as active in DOTS, but was offering a monthly support group. And we all had been talking, it's just one day a week, certain hours, not everybody can make that time, but we had been talking about as a group, a couple, each of us committing to a couple of months a year would be much more. Working on collaborative projects like that is something that we've had been planning to do before COVID, and then we just haven't gotten that back. But being able to offer those wider services is another asset, I think, to having those connections. We also present together sometimes at IOCDF conferences and just generally collaborate a lot.
Okay. So, and yeah, it sounds like potentially, as if they're interested, some people could join you in your practice and grow that.
Absolutely. We're always looking to expand and support new clinicians that are interested, but not quite at that specialist level, to help support and train and bring them into the fold. Very supportive. I mean, we don't have, a competition for clients. I think most OCD specialists don't, because it's not just in Dallas, but it's everywhere that there aren't as many as we need. So just having that sense of collaboration and coordination and not really competition at all, and encouraging the growth of other people in their practices is a primary goal.
Absolutely. Yeah. So in terms of creating that environment, the supportive environment, how do you see yourself doing that? How are you going to create the environment that you wish you had in a group practice?
Yeah. So there's some general culture questions I think a lot about. What is the culture of my practice? What do I want to create? I definitely want the clinicians in my office to feel supported in terms of their ongoing learning and training, but also supported, financially, so that they feel like they are able to really flourish. So paying them what they're worth, making sure that they have also flexibility and freedom to take time off when they need to. We preach a lot in this field about not burning out. We understand it maybe better than any field, and yet we still subject ourselves to it. And so making sure my clinicians have ample time off, that they can work from home, that they really don't have to ask for time off so much as they let me know. that they have something going on, that they have coverage. Whoever is covering knows that they're covering, and that they still are able to get their caseload and their expectation for the number of clients that they see taken care of, even if that, so for some people that means working steady through the week. Sometimes that means working 4 days a week. And sometimes it means like working longer days and, sporadically. And, just also in the office place, keeping things collegial, just simple things like offering snacks and drinks and food for people that may have forgotten a lunch, or that just you're hungry in the middle of the day. I encourage my patients to do yoga, and lay on the couch and take a nap if you have time. You're not cheating. You're taking care of yourself in a way that you need to take care of yourself.
Do you mean to say therapists? Yeah, you said
Yes.
patients. Okay,
Oh,
okay.
therapist. Oh,
Yeah,
did I say
gotcha.
patients?
Yeah.
I'm sorry. Yeah, it would maybe not be the best use of their
Use it to,
time
yeah,
because
exactly. Yeah.
I'm sorry. Yeah, I misspoke.
No,
But yes,
no, just
have
want to clarify.
therapists, take a nap.
Great.
Patients might do yoga with you for sure as a way of managing their stress and practicing that.
Yeah.
But yeah, just one of my pet peeves is that whole like, who left their dishes in the sink, or who ate my Twinkie, like I don't want that to, I just want people to, this is hard work that we do.
Yeah.
It's exhausting. It can be emotionally draining, and making sure people are comfortable taking care of themselves, and feel like they're treated fairly and valued.
Yeah, that's awesome. Well, and that independence and quality of life was a big factor for me in becoming a clinical psychologist. So, and I imagine it's the same for others. So I think that goes a long way.
Yes, that really draws people into private practice. And if that's something somebody wants to do, I want to support that as well. But I also really want to keep people, because I think that, that team environment, that there are things that led me away from group practice. And I want to make sure that those things aren't reasons that other people are leaving my practice.
Yeah, exactly. So, are there any other lessons you learned in group practice that you teach someone who's starting off? Or
So do you mean like the clinical side of things, or entrepreneurial, like kind of business side of things, or both?
both?
Both. Okay. So I think from a clinical perspective, really staying attuned to ongoing assessment is really important. We kind of laugh because it's always like you do the initial consultation or even the intake, and okay, this is a simple case, and then it almost always isn't. Kind of being aware of like the trauma that sometimes people brush over, that ends up later becoming apparent that it's really integral to understanding the case conceptualization. So always keeping a mind on that. What else are we possibly missing? And doing a very full diagnostic assessment and intake at the front of therapy. Another big thing that I feel like is really important, and this is probably something that I have learned more through the clinical and child and adolescent clinical training that I've had, but also absolutely applies to adults, is, two things. One is that really understanding what drives an individual, what motivates them, what are their dreams, what are their goals, because a lot of times when you find that stuckness, there's something about their life that they want to change and they feel like they can't, or something that would reinforce them, but they're not really in touch with that or reaching out to that. So what life and what things does a person want? Because when as we know, positive reinforcement is the main, most effective way to change behavior, and teaching, parents how to do that with their children, and teaching adults how to do that with themselves. That second piece I was mentioning relates to just basic emotional and social skills that we assume adults have, that are often developed in childhood, but that are often missed. So affect identification and expression is a big one. So learning, what is this emotion I'm having? How do I identify it and express it appropriately and adaptively is almost always something I work with on a patient. So with a patient, it's sort of bringing it back to ground zero. Same with in a cognitive behavioral model. What's the difference between what I'm thinking and what I'm feeling? And how do those things interact? And, just some of those kind of, things that you might easily miss, but are so vital to building everything else on. And then I think this kind of bridges the clinical and the professional, or, kind of business oriented learning points, but consulting, keeping those connections with other professionals. Everybody gets stuck at times, or they, kind of have this, vision and conceptualization of a patient that they kind of can get tunnel vision, and having that other perspective is so vital. Really understanding your competence and the limits of that, and when you need to refer, and then just always learning. Always, there's always something new or something old that you didn't learn in your training that is sort of invaluable to how you approach a patient. So an example of that would be in the last year or so, learning more about the research and the literature that's come out of codependence, and just basics. And this kind of goes back to that fundamental lessons, but understanding emotional boundaries, and having some sort of framework by which to say, this is, I think that P.M. Melody's work does this really well, where it sort of clearly defines an emotional boundary, and the idea that we're responsible for our feelings and not the feelings of other people. So that is their responsibility. Our responsibility is to have our boundaries and to communicate those. And so there's a lot of entanglement between my feelings and your feelings, and I don't want you to feel that way, or you made me feel this way, that can be simplified and really then dealt with once you have that framework. And that this was our field goes through trends in terms of, everybody's got codependence back in the 70s, 80s, when the research, when that framework, and I don't know how much actual like scientific research has been done about it, but it was certainly very trendy at that time. And then we tend to sort of push that aside, and no, there's newer, better things now. We're going to forget about that, and it's not important. But even like some of the concepts from psychoanalysis, I think, can be useful. Although I'm not at all psychoanalytic, I'm dyed-in-the-wool CBT. This is the foundation of our field, and so there's probably some nuggets of wisdom in there that we need to continue to learn about and see how they apply in our current practice.
You said PML work. Did I hear you correctly? With in the context of codependence, maybe I just misheard you.
P.M. Melody is the author, I think, is who I said.
Oh, gotcha. Okay.
Yeah.
Gotcha. And in terms of ongoing assessment, is that formal, informal? How do you do that?
For most part, it's informal, but then sometimes there's a referral that's needed for a psychological assessment. Like maybe, oh, wait, underneath all this depression, I'm hearing ADHD. Let's make that referral, and maybe that's actually where some of this all started.
Okay. Yeah, you mentioned sometimes we get tunnel vision, and that's where a consultation can help. Yeah, it's true that with consultations, sometimes we don't know what we don't know.
Yeah.
And just getting another perspective can just open up a whole nother way of looking at it.
Absolutely.
What do you do to keep in touch with the growing literature?
Good question. I primarily attend conferences, and when I'm in professional Facebook groups where these, that's where I first heard about inference-based cognitive behavioral therapy from other colleagues, building relationships that way. and then kind of going out and once you hear something, exploring it independently by the book,
Yeah.
watch a webinar or something like that. There's my primary professional associations are the Anxiety and Depression Association of America, or ADAA, and the International OCD Foundation,
Gotcha.
IOCF. Yeah.
Well, I congratulate you for staying on top of the research, because
It's hard. I don't know.
yeah, no, that's good. It's great to, I believe, having a growth mindset, not just for our clients, but for ourselves, to keep challenging ourselves to grow.
Absolutely.
Is there anything that I haven't asked that you think would be helpful to talk through? Or
I think, you did ask, and maybe I didn't answer completely the lessons from business,
yeah. Mhm.
which I think those are probably the bigger lessons for me, because it's not something that we really talk about or learn in graduate school. We don't really, as many people go into private practice, there's very little training that we get formally on how to do that. So one of the biggest lessons I learned from that is you don't wait until you feel like you're ready, because it's unlikely that you will ever feel ready.
Nice.
There's always these leaps of faith that have to happen. And more often than not, you find that you're good, like you're solid. And you are going to mess up along the way, but I think imposter syndrome can really freeze us and be kind of paralyzing, where we're like, I've gone all this training, but I don't know that I'm ready yet. And I think sometimes in the consultation, you find out like, you actually have a lot to add that maybe somebody else didn't think about. And so, growing through that, but also just sort of, for me, especially with being an anxiety specialist, like having to practice what I preach in terms of step into that discomfort. And that's the way you're going to grow. And then with that, as a professional, and kind of keeping in mind the imposter syndrome and that kind of thing, is really creating boundaries and honoring your worth. So I still struggle with this, and it's a constant reminder I have to come back to, is like a time boundary. Your appointment is a certain amount of time. You really try to honor that. If you go over it, then you have to, value your worth and your time, so that you have a conversation about charging what you're worth and charging what that hour in your schedule has been agreed upon is worth, or that hour and a half if you end up going over. And so making sure to have those boundaries, and really, the more you do that, the more you realize the client is happy to pay the extra fee for that 30-minute phone call outside a session or whatever. But even then, there's some limits, having kids and a family, having to also balance, like, I need my time off, and I can't, I think in private practice, we start calculating every day off is worth this much. And so that we kind of push ourselves a little bit too much, but making sure that we set aside that time for recreation. And then and just like following your passion is also really important. I think that I would be much less happy if I were doing in a sort of niche in the field that I wasn't so excited about. That I really love the work that I do, and it took me kind of a roundabout path to get here, but it was worth it to kind of stop at these junctures and think, like, is this really fulfilling in my life? Is this something I want to spend the majority of my waking hours in a week doing? And if the answer isn't an enthusiastic yes, at least most days, because some days you're just not going to, but then being willing to reconsider and change paths, even if it means a setback, or sort of taking steps back in order to move forward. Yeah.
Regarding the entrepreneurial growth, who or what have you learned from the most?
That's a really good question. I have colleagues whose group practices are grown more than mine. So Amy Mariaskin in Nashville, Josh Spitalnik in Atlanta. Like, these are people that I've connected with. I met them at professional conferences, and then they've, most people are just so generous with their time that they will help you, or if not, you pay them as a business coach for their time. There's other resources available, so through Facebook, and then through a sort of a private membership program. There's the group therapy practice exchange, I believe is what it's called, where you can kind of pay and get access to lots of resources, and they have workshops on growing a group practice. And then there is Therapy Practice Institute, which is a little less sort of tech savvy, but is also something that they have weekly meetings and one-on-one consultations if you join as a member for that as well.
Okay. Well, speaking of being generous with your time, thank you so much, Dr. Martinez.
Yes, thank you for having me. And it's a great podcast. I appreciate this endeavor that you're doing as well.
Thank you.